Hello, my friends. Jill Osborne from the Interstitial Cystitis Network. It is Sunday, March 27th of the year 2022, and it is time for another live IC support group meeting. Oh crap, hold on a sec. I gotta check my sound settings. Oh, yep, screwed that up. Hey, I'm not perfect. All right, let's try this again, shall we? Hello, my friends. It's Jill Osborne from the Interstitial Cystitis Network. It's March 27th of the great year of 2022. This means we have survived a couple more previous years that were very hard. And my purpose in doing these meetings is to make you so strong, so knowledgeable, so informed that no one can mess with you again. I don't want anybody telling you this is all in your head. I don't want anybody telling you that you're damaged goods. I don't want anybody telling you that there is no hope or telling you that you will be a burden on your family. That is a load of you know what. All right, now I've got to fix my camera here for YouTube. All right, we are streaming live on Facebook and YouTube. If I'm looking here, I'm looking at Facebook. If I'm looking over here, I am looking at YouTube. Hello, Boria. Hi, Joan. Hello, YouTube. So this is our normal Sunday meeting. I did not do a meeting last Sunday because I hurt my back, and I'm better now. But, you know, things happen. Life happens. Now, if you guys could do me a favor and share this with some of your groups on Facebook, that'd be great. Let them know that we're live right now. Hello, Mandy. Hello, Kayleen. Kayleen, girl, how are you feeling today? Are you better? A little bit, even a little bit. Thank you. Thank you, Carolyn. Thank you very, very much. Hello, Donna. Thank you, hon. Hi, Callie. Nice to see you. So you guys, for anybody who has questions about diet and nutrition, you can talk to Callie Kragier here on Facebook, who is a registered dietitian working with IC patients. We did a fantastic podcast that I put up this week. We had a great time. Callie, right? We had a good time, right? For 90 minutes talking about all things IC. You can listen to the podcast on the link on our Facebook and as well as on my Twitter account. And hopefully we'll do another one. I think it'd be great. Hello, Ashley on YouTube. Nice to see you. Nice to see you. Kayleen, a little bit, not my, hey, girl. Hey, listen, we're going to take a little. A little is better. You're frustrated and tired, nervous for my 2 appointments coming up on Tuesday since I have to put my foot down. Yep. Yeah, Kayleen, one of the things that I did early on, now, you guys, I have no shame. I will pretty much talk about anything, you know that. And I've been very honest in sharing that I had severe anxiety disorder in my 20s. Hi, Lisa, just severe anxiety disorder. And as I was trying, oh, thank you for putting the link up, Callie, much appreciated. As I was trying to because your 20s are hard because you're trying to figure out who you are. You're not a kid anymore, but you might not have the answers to your life yet. There's nothing harder than being 25, 26 years old and people are saying, hey, why aren't you married? Why aren't you having kids? Or why don't you have the job of your choice? And for many of us, the 20s was a decade of discovery as well as a decade of harsh lessons. And finally learning to stand up for ourselves. I think it's just so incredibly important that we walk into life with no shame or no blame, but that's very, very hard when you're in your 20s. It's very hard. It's very easy to let somebody insult you and not stand up for yourself. And hopefully one of the things that I'm accomplishing with these meetings is helping you stand up for yourself a little bit more, right? I want you to do that. So anyway, I was reading one book. I don't remember what it was back in my 20s. And it was about anxiety. And it said, if you're not sure how to present yourself at a appointment, like a doctor's appointment or a meeting with an attorney or with family or whatever, something that's going to be a little bit conflicted. try to channel somebody that you really, really respect and ask yourself, how would they walk into that meeting? How would they conduct themselves in that meeting? And for me, guys, remember, I'm a wee bit older now, so this was 40 years ago for me, or 35 years ago when I was doing this. The role model that I picked was Shirley MacLaine, who is an actress, a redheaded actress, but she was really known for just standing strong, standing firm, speaking out, being bold, being educated, competent, knowledgeable. And she had her moments when she was a little bit out there, just like I have moments when I was a little bit out there. But I actually did that a couple of times, like with job interviews, or if I was going in, with just something that I thought would be a little bit stressful, or maybe even like a party, because some of us are introverts, right? Some of us do better in small groups. We don't do really well in big groups. And so if I were going to like a wedding, and I wouldn't know anybody there, I would just like kind of walk in like Shirley MacLaine and pretend to act like how I thought Shirley MacLaine would act. So hopefully I can kind of pass that along. And in the sense that if you're walking into a meeting with a doctor and you just don't really know how to approach it, ask yourself, how would I handle it? If you want to, I mean, symbolically, I'm standing right next to you at every meeting, right? You know that. Or even behind you, pushing you forward a little bit. And so, Kayleen, when you go into that meeting, head up high, strong, knowledgeable. You're paying them, they're not paying you, and you're seeking information, you're seeking knowledge, you're seeking their experience. Ruth says, I hope you're okay. Thank you. Anne says, how do you know if you need to use estrogen cream? If you're dry, hun, if the doctor looks at your skin and you're dry, then yeah, estrogen atrophy. Joan says, I know it has nothing to do with IC, but you went to a Ukrainian benefit. You fell down the stairs, hurt your leg, 11 hours in a waiting room in the emergency room with sick people, no break, but acquired pneumonia from the ER. Holy hell, Joan. Girl, you're trying to do something good and you got slammed. Guys, for just please understand right now that we are now in another surge with a more aggressive, more contagious virus right now, the second Omicron variant. And so please protect yourself. This is not the time to go to into a small room, closed room without good air circulation and not wear a mask and even glasses, right? Because now this is probably the most virulent variant, a mutation of the COVID yet. And it's here. It's here in California. It's here in my county. It's everywhere. It is I think it's a dominant strain in the US now. Maria says, I was put on amitriptyline. I used it last night, having horrible side effects today. A lot of stomach pain, headache. Is there a similar medication for nerve pain that works so well? Well, Maria, amitriptyline is a low-dose antidepressant, which when used in small amounts over time can help kind of calm the nervous system down. But unfortunately, amitriptyline does have a lot of side effects. It doesn't normally cause stomach pain, but the headache I can relate to. But generally, amitriptyline is known for causing dry mouth, dry eyes, racing heartbeat, irregular heartbeat, weight gain, sugar craving, etc. You want to call your doctor and let them know that the side effects you had, and maybe you just did too much. So, amitriptyline is one of those medications where they would, hi, Mary, where they would prescribe it for depression in really high doses. Like they might start you at 25, get you to 50, and then get you up to 75, which is kind of the dose that, if I remember correctly, is the ideal dosage for somebody struggling with depression. But we're not taking it for depression. We're taking it for try to reduce pain. And so generally patients with amitriptyline, I see patients who use amitriptyline start at a very, very, very low dose, like 5 milligrams. Even I think it was Dr. Moldwin in a lecture on our website talked about people who are sensitive to amitriptyline, and he would have them kind of crush it and just take little pieces of it to slowly build their tolerance to it. But that said, remember, it's all about your subtype, hon. If your underlying issue is muscular, amitriptyline is not going to help your muscles over time. What's going to help your muscles is pelvic floor therapy, right? Ruth says, a urologist says to take Allura. What do you think? Well, Allura is an over-the-counter. It's the single most popular over-the-counter medication for women with recurring urinary tract infection. It is a proanthocyanidin supplement, PAC product. The research behind it is absolutely solid. Very, 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 very good. The challenge with Allura is that it is expensive. The over-the-counter cost is quite expensive. And so instead, Natural Approach Nutrition, the company that makes Bladder Builder and Bladder Rest, they were asked by Dr. Ken Peters if they could create perhaps a more affordable option, and they did, and that's called Prevent. So Prevent, it might be $60 a month, whereas Allura might be $125 for the bottle. But it's for UTI. It's not for bladder pain. It's not for muscle tension. Mandy says, I was listening to a podcast this week, and it's two doctors who discuss medical information. They just did an episode about IC, and it was so outdated and misinformed. They said that IC is a catch-all for anything urological when there's no evidence. Well, honey, that's actually correct. That's not uninformed. That is correct. Interstitial cystitis, especially in the United States, is what we call a grab bag diagnosis. It means that you have frequency, urgency, pressure pain in the absence of an obvious cause. In other words, they've ruled everything else out. They've ruled UTI out. They've ruled cancer out. They've ruled other things out. But we've come far from that, so now we really think of IC not as a bladder-centric condition. We think of IC as a pelvic pain syndrome in which structures outside of the bladder are often the cause of this. Technically they're right, but that's like 10 years ago. Sue says, have I heard anything on low-dose naltrexone? Yes, there has been some research on low-dose naltrexone that is encouraging. Let me grab it real quick, and because I don't want to try to give you the wrong information. Now, you guys, I always need to tell you that I'm not your doctor. I do not give medical advice. My job is to educate, inform, and send you back to your doctor with better questions. With perhaps, if necessary, a little kick in the tush to get you there. All right, so hold on a sec. Let me see if I can find this study. All righty. There's actually a there is a clinical trial right now on low-dose naltrexone and interstitial cystitis that is currently being done at Stanford University. Now, let me get to a published study here. Hold on. Nope, that's a clinical trial too. Hold on. Naltrexone. A lot of studies using low-dose naltrexone for chronic pain. A total of 793 studies were obtained. 8 articles were selected. 6 studies included data on fibro, 2 studies and data on regional pain syndrome. 1 examined multiple diagnoses, including interstitial cystitis and chronic pain. Low-dose naltrexone provides an alternative in the medical management of chronic pain as a novel anti-inflammatory and immunomodulator. It can offer additional management symptoms such as for orofacial pain condition. I will say that I honestly haven't talked with a lot of IC patients who have done it. So I don't have in my memory, this crazy brain I have of many things I see, I don't have a good case study to share with you on low dose naltrexone. Erin said she just got off LDN. It helped her IC, but you were hungry all the time and you gained weight quickly. Penny says she's on LDN. So did I. My doctor wanted to try it. You've been on it for 10 months. You had a flare last month, but it was like cramps, not debilitating, which is great. Hi, David. Kayleen says, what about Eucora? I've seen it advertised. Honey, Eucora is for UTI. Look at the ingredients. The ingredients are pretty irritating for IC. We don't recommend Eucora for chronic pelvic and bladder pain. It's really only for patients who have recurring UTI. We just... Penny says when she was on low dose naltrexone, she lost over 30 pounds. Just shows how we're all so wired so incredibly differently. So I filmed a couple of TikToks this week, and it's hysterical because I was trying to do it in my office and the sun was just not right. So I did it out on my deck, sitting on my deck. And so if you go over to our TikTok page, you can find a couple of more TikToks, and these specifically are about flares. Oh, Mandy says, ignore me. I can't tell. Honey, do not worry. It is okay. Okay, hold on a second. Wait. Pamela says she's been screamed at. More than one hospital sent me to doctors. You drove 100 miles one way to be turned away, never looked at me or talked to me. Walks in, sending me to another state to a doctor. I drove to a doctor. You drove to Tennessee to see this doctor living in Kentucky. You go to Michigan, right down the road, drove 4+ hours to Dr. Saw, 2 over. Wow. It's crazy. You know, understand, guys, that there are 3 levels of doctors. There's the local doctors, there's the regional doctors, and there's the national doctors. Local doctors are your first step. And even at the local doctors, your primary care, who would then send you to either OBGYN or urology. The challenge with local doctors is that they just, number one, they don't have the time or the money necessarily to go take classes. You're not going to find a lot of local doctors interested in IC or chronic pain. You're not. So if you're going to very, very quickly outpace the skill set and knowledge level of the local doctor. And so that is when you go to a regional doctor. So here in Northern California, my regional doctors are 80 miles away in San Francisco. Okay. And it's that regional doctor, normally at a university, who is going to have much more experience working with the typical pelvic pain interstitial cystitis patient. And so hopefully you can have some success with that. But some of you are so complex that you could outpace the skills of the regional doctor, and you may instead need to go to one of the national doctors, because it is the national doctor who has seen thousands of patients. They're the ones who go to the conferences, they do the research, they teach other doctors. And so, you know, you can understand that you can go from local doctor to local doctor to local doctor to local doctor, and you're probably not going to get very far. You've got to go to a regional doctor, normally at a university, once the local doctor is kind of done. Now, understand too that most health insurance companies will pay for that referral, but you have to push buttons. You know, because in general, doctors are discouraged from making a referral because the health insurance company doesn't want to pay for that. You have to be persistent because you're entitled to that care. You are entitled to see somebody who is knowledgeable. So once you give your local doctor 3 months, 4 months, 5 months, even 6 months, and you're just not making progress, that's when you go, is there a doctor in the area that specializes in pelvic pain disorders or what we would call urologic chronic pelvic pain? And ask for a referral. Ask for a referral. So traveling, as hard as it is, when you're in terrible shape, you are crying your eyes out, you're not sleeping well, and somebody goes, hey, you got to drive 100 miles to go see this doctor. And you're going, how the hell am I going to drive 100 miles when I can't drive 5 miles without crying? Right? You know what I mean. You know what I mean. I've been there. You can make it happen. You can make it happen. If that means that you hire an Uber, or that you ask a friend to drive you so that you can lay down in your back seat. Bring a travel john so that if you need to urinate while you're in the car, you can easily do that. But the expertise that you're going to get, that regional doctor or that national doctor, is very important. Don't assume that the local doctors are going to be able to give you everything. They're not. They might not even have the equipment to properly laser a Hunner's lesions, right? Sherry says, any advice on urethral burning while urinating? Anytime I've had it, it's always linked to infection. Now started to have it without infection, almost 30 years with IC and 5 years of pelvic floor. Shari, can we say estrogen atrophy? Anytime. Now listen, if your urethra has been burning for the last 20 years, or 30 years, and it has been a long-term consistent symptom of yours, then we really have to look at the urethra itself to try to understand if there's anything wrong with it. If you, for example, have your doctor's doing urethral dilations because your urethra is narrow, then rather than just forcing it open with a dilator, normally what we would do is ask, why is my urethra so narrow? And that usually comes down to tight pelvic floor muscles, tight levator ani muscles. So when we think about urethral irritation, we're going to think number one, estrogen atrophy, because you're a canary in the coal mine when it comes to estrogen changing your skin. So number one, estrogen atrophy. Number two, tight pelvic floor muscles. Number three, chemical irritation. When we used to wash our laundry in Sheer or Tide, within 5 minutes, I'd have urethral burning. Easy. The chemicals, especially fabric softeners, leave chemicals in your underwear, which then irritate that skin. And so we want to look at chemical irritation. And then last but not least, we also want to look at perhaps, is there an infection of the periurethral gland, which is halfway up the urethra? So if your urethral burning has just started as you've gotten older, we're going to go right to estrogen atrophy. But if you've had urethral burning for decades, and we have to understand what's wrong with the structure of the urethra. Could you have a urethral diverticulum? So, and I've shared this story before. This is a really interesting story. This is good. Actually, this is a really good story for you, or a patient report, Shari. So we had another IC patient who all the symptoms of IC, diagnosed with IC for decades, right? And she saw many doctors, and she kept saying, my urethra hurts. It's my urethra. And they were giving her all the bladder therapies and nothing worked. She did installation. She did the, typical oral medications. Nothing worked. So she kept going from doctor to doctor to doctor looking for help. Well, finally, I think she was with a nurse practitioner, and she said, it's my urethra. It's my urethra. And the nurse practitioner said, hey, let's get some imaging. So when they did an image, I think it was a CAT scan or an MRI, you know what she had? She had a massive urethral diverticulum. A diverticulum is a little pocket that extends away from the bowel or away from the urethra. So your normal urethra is kind of like the length of your little finger. Well, she had a little tiny tube that went to a hollow structure exactly the same length and width as her urethra, but it didn't connect anywhere. It didn't drain. Urine was sitting in this pocket. diverticulums happen often from straining really hard. So what they did, so the reason why she was in so much pain is she basically had infection in the diverticulum and she was straining a lot. So they surgically removed that diverticulum and bam, healed. So you got to be the squeaky wheel here with your urethra. Betsa says, why recurring bladder infection? Well, so recurring infections happen in patients who are compromised in some way. So we most often see recurring infection in women who are either on birth control or are in surgical menopause, chemical menopause, or real perimenopause, menopause. Understand that your bladder is a very unique organ. It is the only organ in the human body designed to hold toxic waste, right? Because urine contains body waste, ammonia and urea and all that sort of stuff. So there's kind of an evolutionary marvel in the bladder, because how does the bladder protect itself? How can the bladder protect itself from all the chemicals? Well, it turns out your bladder is like your mouth. It's a hollow organ covered with a really thick coating of mucus. We call it the mighty mucus, and that mucus acts as a barrier. It protects the skin of your bladder from anything in your urine, whether it be chemicals or whether it be bacteria. So this nice thick coating is essential to bladder health. Unfortunately, it is estrogen dependent. So when you're young and have lots of estrogen, you have lots of mucus. You can get away with stuff, but guess what? When you get older, bam, you don't have as much estrogen. Therefore, you don't have as much mucus. Therefore, your bladder's ability to defend itself is now severely compromised. So these are the women who often get recurring UTI. So I attended a lecture on this years ago, and it was taught by Dr. Anthony Schaefer, and I think it was at a National Institutes of Health meeting. And one of the things he said is, number one, if you have more than two infections in 6 months or 3 infections in a year, we no longer call it a simple UTI. It is now to be labeled a complex UTI. And they have done a lot of research trying to understand why this happens. So in their research, they took daily urine samples, they took daily vaginal swabs, trying to understand what the hell was going on. And they made a remarkable discovery that about 24 hours before that specific bacteria arrives in the bladder, it is living quite happily in the vagina. And so this then led the doctors to go, well, wait a second. Why has the vagina become a safe haven for bacteria? And the answer comes right back to estrogen atrophy. So not only does your bladder rely on estrogen, your vagina relies on estrogen to produce that nice, thick coating of mucus. And so generally in an older woman, or again, surgical menopause, something like that, what they're going to do is, in addition to giving you the proper antibiotic, normally they would also give you a topical estrogen cream to use vaginally to help restore the health of your skin in your vagina. So it too is better at defending itself from bacteria and making the environment more bacterial challenging, if that makes sense. Beth says, I'm curious to know more about the different subtypes. I've been in a flare for 2 years and I've had IC since my teen years. I've tried many treatments and they only work for a short time. So let's talk about, so Claire is introducing the concept of embedded UTI. Now, Claire, you've been to meetings before. You know that I do not believe that everybody has chronic UTI, and in the IC community, I don't know a single doctor who does, because we have a lot of patients whose symptoms begin after trauma. So if a patient's symptoms began after falling on their tailbone, that's not a UTI. That's a musculoskeletal problem that's triggered their pelvic floor, which is affecting their bladder. Or for patients whose symptoms begin after chemotherapy or during chemotherapy. I've been working with a lovely young man with leukemia who, is it leukemia? Anyway, he just finished his last round of chemo, and before chemo, he'd never had any bladder issues, and his chemo just devastating his bladder. And I've talked to him several times in the last year as he's been going through chemo to try to help him. So that's why we do subtyping, because we now know that a one treatment futsal approach does not work. There are some patients who do have recurring UTI, but we have to put these into context. So let's think about our subtypes for a moment. Subtype number 1 using the Crispane subtyping system is Hunner's lesions. Hunner's lesions. Hunner's lesions have now been connected to viral infections. So a Hunner's lesion is a big bloody wound in your bladder wall. Let me get my slides here for a moment. You would think I would have everything set up, but no, I was feeding my parents right before this. Cream chip beef on toast is what they had. All righty, so here are some pictures of Hunner's lesions, okay? And Hunner's lesions generally have a center, and then they have arms radiating out of the center. And when you biopsy a lesion, there is massive inflammation. So it was the European community who about 5-6 years ago, they were the ones who discovered that patients with Hunner's lesions often had a specific virus in their urine called the polyoma virus. And now the U.S. National Institutes of Health has also made that same discovery. They too were doing their own viral studies, and they too found the polyoma virus in a small subset of patients. So viral infection is possible with Hunner's lesions. Hunner's lesions may also be the result of neuroinflammation, and we had a remarkable case study published last summer, which of a lady with extremely severe Hunner's lesions and an extremely severe prolapse. And when they went in to repair her prolapse, they discovered that her uterus was backwards. So the front of her uterus was facing backwards, and the back of her uterus was facing frontwards. And the reason why is that one of the ligaments that normally holds the uterus in place had broken. And so her uterus was now swinging from one support. And so it had swung completely backwards. This is called posterior fornix syndrome. So the remarkable story in this case is that when they resolve the strangulation, when tissues twist, we call it a strangulation because the twisting ends up blocking blood flow and damaging nerves. And so it could be, they call it torsion, but it basically strangulation. So when they got her uterus back in the correct position and restored it correctly and resolved that strangulation, something absolutely remarkable happened, and that is her Hunner's lesions healed completely. So this is yet another example that is very clearly not bacterial in nature. Okay. IC subtype 2, bladder wall driven. These are the patients who have real bladder symptoms. There's no doubt there's an underlying issue with the bladder. We're going to look for 3 primary things in this group. We're going to look, number 1, for chemical irritation. So these are the patients whose symptoms begin after chemotherapy or from drinking way too much diet soda or coffee or whatever. The bladder can be injured just like any other part of the body, and it's often injured with chemicals. Number 2, we're going to look at estrogen atrophy because that also directly affects the bladder wall. So if your symptoms began after having a hysterectomy, after going through chemical menopause, or as you've gotten older, we always have to look at the quality and health of your skin. That's not a disease process. And then the third thing we do want to look at is chronic infection. We do want to look at that, no doubt about it. But we don't just want to look at chronic bacterial infection. We want to look at chronic fungal infection. So again, it was our own U.S. National Institutes of Health 7 years ago who made a remarkable discovery, and that is that many IC patients who are flaring have an overgrowth of candida in their bladder, fungus in their bladder. And, people kind of laughed that off at first, but now we have yet another brand new study from UCLA, very rigorous research study, which again found a very pathogenic candida in the urine of patients with bladder pain. This candida was very damaging to tissues. It was extremely virulent. And so again, we want to look at virus, we want to look at fungus. And the other thing that I think is worth saying is we're also doing a lot of these urinary biome studies or trying to understand, what a healthy bacterial biome is versus a damaged biome. And so there we've had a lot of research over the years going all the way back to Susan Kie, University of Maryland, even farther back than that have looked at the urine of IC patients versus the urine of normal bladders to look for any bacterial differences. And they consistently do not find any difference in our bacterial biome as compared to somebody without bladder disease. And yet another research study came out in the last couple of months, which confirmed that. So our question now is, what is an embedded infection? An embedded infection is an infection which could be much deeper in the tissue. This was first brought to us by Dr. Paul Fugasato years ago. PhD, ran a lab in South Dakota, and he believed that IC patients had what he called a fastidious infection. And that's what we all did 20 years ago. We all sent him our urine, and we all waited for the results just to see what they could find. And he did indeed find Enterococcus and Micrococcus most dominantly in patients. I had my sister sent in urine, I sent in urine, my mom sent in urine. We all had identical results, Enterococcus, Micrococcus. And now we know that despite his lovely heart, I mean, I met him, I had lunch with him at a conference, sweetest, nicest man. He really was fighting in a very nice professional way at a very, very advanced age. Imagine being 80 years old and coming into a urology conference where people scoff. He did it. He was really trying to advocate for you. But unfortunately, his method was flawed. His method was flawed in his urine collection methods because he would send us glass bottles, a little glass bottle about this big, and we would send it back to him by express mail, right? Unfortunately, we now know that bacterial biofilms survive autoclaving. And that's how he sterilized his glass bottles, is with autoclaving. So we now think in hindsight that there was a lot of cross-contamination in that. But is it possible that somebody could have a chronic bacterial UTI? Yes. I do not believe that it is everybody. It's nowhere close to being everybody. I think it's a very small subset. If you think you have chronic infection, whether it be chronic bacterial or fungal, you can have a next generation DNA urine test and see if that could reveal something. Why not? And Claire, I do want to say a heartfelt condolences on the loss of Dr. James Maloney. He was one of the good guys. Yes, I disagreed with him, but that is certainly not going to take away his legacy. He dedicated his career to helping patients, and we all owe him a debt of gratitude for dedicating his life to helping patients who are often ignored and often scoffed at. And he left a fabulous book as a resource, and that's a tremendous gift he's given to all of us. Erin says, any suggestions on a regional doctor? I live in Ohio. You're going to have to look at the universities, like Ohio State University. Mary says the audio is chopped up. Anybody else having problems with the audio? Mandy says, do physical therapists ever review x-rays or imaging tests? Sometimes. Shari says, going through menopause now. Yep. That's my OBGYN. So Shari, Matt says on YouTube the audio is great. Good. Um, Here, hold on. Mary said on YouTube, and hi Barbara. If I didn't say hi already. Thank you, San Marco. Marco says no issues. Mary says, my pelvic floor physical therapist is having me do Kegels. I went to my naturopath to check up. His assistant checked me out and said, I should not be doing Kegels because you're tight. Absolutely correct. You would never be doing Kegels if you have tight muscles. Remember, your muscles are supposed to be long and loose and kind of, I don't know if soft to touch is the right way to describe it, but your muscles are supposed to be long and lean, for lack of a better term. And if these muscles are tight, what happens? What's the legacy of tight muscles? It doesn't just squeeze the muscles, it squeezes the nerves and the blood vessels. So the last thing we want to do is a Kegel, which will tighten them more. Kegels are specifically excluded for patients with tight pelvic floor muscles. Excluded. You are not supposed to be doing them. If a Kegel hurts, that means that you have tight muscles. And so whoever you're working with has not been trained properly. There is a certification that you should look for as you're going for pelvic floor physical therapy. It's the name of the training company is called Herman Wallace. So hermanwallace.com. They're the company that does all of the certifications of pelvic floor specialties. And so they're the ones who do the pelvic pain certification or pelvic floor health certification. And so ideally, if you can find a physical therapist with that type of certification, you are gold. The way you can find it is at pelvicrehab.com. Pelvicrehab.com is a website that lists all of the physical therapists who have been trained, they're certified, or they're in the process of getting trained. Matt says, this is Matt's wife, by the way. Hello, Matt's wife. Let me get a drink of water here. Hold on. Hope you guys are feeling, like I'm feeling pretty good today. Feeling a wee bit fat. You know how you have your days where you're just a little bit bloated. Don't know why. So I'm going back down to my very simple foods. But I feel pretty good. I hope you guys feel good. Mary says she's been doing this for 35 years. I have been doing this since 1994. 1994. Which, if Callie is still watching, so this is hysterical. So again, for those of you who come in late, we did this really fun podcast with Callie Cregier, who is a registered dietitian working with IC patients. And I've got links for that on my Twitter feed, on her Twitter feed, and on our Facebook page here. So as we were talking and she kind of wanted to know how I got involved, I was like, well, I got started in 1994. And she goes, I wasn't even born yet. And I laugh because, on the inside, you're the same person. I'm like the same person. In my brain right now, I am 25 years old. Like I'm not even 30 in my brain. I'm like 25 years old. That is the age my brain is at. And so even though I'm older, and I do realize that people are, that I got involved along, that there are people who weren't born when I got started. It shocks me because I just don't feel that old. It's funny. Brenda wants to know about installations. Installations are appropriate for IC subtype 2 bladder wall driven. So if we're looking at a bladder wall that's screaming in pain, giving you a lot of frequency, a lot of urgency, one of the things that they can do is a rescue installation with heparin, lidocaine, sodium bicarb, maybe a little bit of steroid in there that can just calm that bladder wall down. But installations really are not going to be effective for Hunner's lesions, and certainly for pelvic floor, stuff like that. Installations are fairly pointless. They would be short term. You always have to focus on the underlying cause. You can get lost chasing symptoms, and that's a mistake. You always have to try to take a step back from the symptoms and work with your doctor to try to understand the underlying cause of this. Mary says, she says your pelvic floor is partially weak and partially tight. Yeah, mine is too. That's very common. I'm very tight down by my levators, and I'm very weak up higher. At least I used to be. So sometimes it's left side, right side. Sometimes it's shallow muscles versus deep muscles. Then they just have to kind of work on that. The first thing they would normally do is you address the tightness first. And then once we got the muscles in good muscle health, then they focus on strengthening. Ashley says, you have a very youthful spirit. Thank you. I try. I was way too serious in my 20s. And I think it was just because I didn't understand what was wrong. I had so much anxiety and all this sort of stuff, and I was just kind of lost. So I was quite serious back then. I'm much less serious now. Dee Dee says, you only have a burning urethra since vaginal hysterectomy and using Premarin cream. Well, Dee Dee, the problem is the Premarin cream. Premarin cream, I think, has alcohol in it. Premarin is notorious for causing a lot of extra burning. And so it comes from pregnant mare urine. And because it comes from horse urine and because it's a brand name with a long shelf life, they use a lot of preservatives in it. And so we don't do well with Premarin. Premarin is very, very burny. So we do better with a compounded preservative-free estrogen cream instead. So you can just tell your doctor the Premarin's causing burning. This shouldn't be news to anybody. This is very, very common, and ask for a prescription for a simplified estradiol cream that you can take to a compounding pharmacy. I use the Women's International Compounding Pharmacy in Arizona. They ship across the country. They specialize in creating products for people who are sensitive. Mary says, therefore, she uses Kegels because of the weakness. Kegels are used, yes, if you have weak muscles, but you're not supposed to use them until you've addressed the tight muscles. Chorito says, is it safe to use vaginal estrogen? I've heard it causes cancer. Chorito, if you Google it, topical estrogen safety, you will find that the research shows that it is remarkably safe, even for patients with a history of gynecological cancers, because topical estrogen stays on the skin. It is not absorbed deeply into the body like, for example, oral estrogen. If you're taking an oral estrogen, yeah, that does go throughout the body and creates a risk. Topical estrogen is much, much safer. I use it. Claire says, I think times have changed and we need to accept this. The number of people with embedded infection is increasing massively. I don't know, hon. I disagree with you. A case study does not show how common it is. A case study shows that it's happening in random individuals. We need a much larger study. And the challenge you're having, Claire, is that the big researchers who are doing biome studies, including our own National Institutes of Health, they simply don't find it, hun. Claire says, you had candida in the bladder in 2014. Yeah, I did too. I had candida in the bladder at least 10 years ago for 2 years because more than that, 15 years, maybe even like 18 years ago, because I did long-term antibiotics and it gave me a drug-resistant candida lebrata infection for 2 years. Oh, that's good. So Claire says that Dr. James Maloney's son is continuing his work. That's great. Kayleen says, you've been doing this for as long as I've been alive. I can't believe I'm older than Callie. But the thing is age, once you're older, it's like, age doesn't matter. Not the hard part about the hard part of being different ages is when you're young and you're trying to figure out who you are. But man, once you're over 20, 25, once you kind of found your place and you found the person you want to be, it's not about age. It's about people who have the same interests in you and the people who want to work with you and you want to work with them. You know, I felt very, I was always kind of an outsider in a way, because I started having my problems in 7th grade when I broke my tailbone. And of course, they all thought it was UTI back then, and it never was. It was the broken tailbone that damaged my pelvic floor. That now that we fixed my pelvic floor, guess what? I have no bladder symptoms anymore. But that said, you know, when you're in the heart of it and you cannot function normally, you feel left out. I felt left out of my life for a couple decades until things started getting better, and that's one of the emotional things we all have to acknowledge. It happened. We can't change the past. I'm not going to obsess over it. I am focused on today. What can I do today to make sure that I will be in good health tomorrow? Which is why I ate my Ezekiel bread with almond butter as my breakfast. And I will have an apple after we're done. And then I will try to have veggies for dinner. We'll see. And I'm drinking water, nothing else. I'm just drinking water today. Mary says, is it okay to eat Dairy Queen ice cream? I'm going for a Sunday drive here in Seattle. Well, I mean, don't do chocolate. If you do vanilla, I mean, I just wouldn't do a lot of it. But I think you're entitled to a treat. And I knew with no shame, no blame. I believe in reward therapy and having a wonderful day. I took my mom for a drive last weekend. We got Slurpees. And, you know, there's an unhealthy food, but you know, that's childhood memories. She wanted a Slurpee. I got her a Slurpee and I had a Slurpee. Maybe, you know, once every couple months. Dee Dee says, yes, you discontinue the Premarin and you're doing much better. Yeah, but have you switched over to another estrogen? Because you still have to work on that skin and give that skin some good skin health, right? Rachel says, can weak pelvic floor muscles be the cause of frequency urgency? Yes, absolutely. David says, does vanilla have alcohol in it? Not in any great degree that you should ever worry about. You know, vanilla extract, I wouldn't worry about any alcohol in that at all. But if there is any, it's tiny and it's just not going to be an issue. Dee Dee says you're working on getting your estrogen. Follow up on Tuesday. Good. Dee Dee, just understand. Now, listen, here's the deal. If your skin is dry, anything you put on it is going to burn it first. Because your skin is dry. Your skin doesn't have its normal defenses. And so normally when you start estrogen, even a compounded estrogen, it's going to feel very warm at first. It might even feel hot at first. It might even feel like it's burning you at first. But every subsequent time you use your estrogen, that gets better and better and better, because your skin is immediately using that estrogen to produce that mucus, which will then help and improve your skin health. And so for me, it took about 10 days for the burning to go away. You know, so you have to ride through that. You're going to have to work yourself through that first 2 weeks. And it should improve very, very quickly. Again, it took about 10 days for it to go away for me. Started out, it probably burned for an hour when I first used it. 10 days later, it's like a little poof of air, like poof. And that's how it is now when I use my estrogen. In fact, I should have used it last night and I didn't. But the challenge here is that the burning comes back if I don't use it for like a week or two. And that it helps me understand that. Claire says there's no challenge now in the United Kingdom because chronic embedded recurring infection is now recognized. This is a mammoth achievement. I agree. That is a mammoth achievement. What is the IC bladder organization? How are they responding to that, Claire? Hold on. So that came out like 13 days ago. The United Kingdom National Health Service has publicly recognized that chronic UTIs exist and has updated its advice for patients following pressure from campaign groups. For many patients who develop a UTI, their experience is extremely painful but short-lived, but for thousands of others, a one-off acute attack turns into chronic infection that dominates their lives and lasts for months or even years. The NHS Digital updated its website last week to provide information around chronic bladder infections where previously there was none. Campaigners say this is a huge step forward, but there's still a long way to go. So Bladder Health UK, this is great. Bladder Health UK was involved in that. Great. This is wonderful. I'll have to do a blog on this. And it says the NHS page for interstitial cystitis has been updated to reflect that some patients who have been diagnosed with the condition may actually have chronic UTI. So you notice it's saying some, but not all. That's our challenge, are the people who are saying that everyone with IC has chronic UTI. It's simply not the truth. Michelle says, yes, I have IC, struggled for years, help me. Oh, Michelle, I'm sorry to hear that, hon. So Michelle, tell us a little bit about you then. How old were you when your symptoms started? How old were you when your symptoms started? And number two, can you remember any event or trauma that you associate with the onset of your symptoms? Like, were you traveling? Were you in an accident? Did you have a baby? Did you go through chemotherapy? Was there any event that you associate with the onset of your symptoms? And how many years ago was that? Carol says, I have non-allergic rhinitis. My doctor told me to take 60 milligrams of Allegra every day, Benadryl at night, Flonase twice, but I feel like it's drying out my vaginal area, and I think being dry down there is aggravating my IC. What are your thoughts? I'm going to tell you right now, I think allergies this year are the worst in a decade here in the United States. Absolutely the worst in a decade. It's ridiculous how bad they are. I mean, Benadryl is known for a drying effect, hon. So I don't know offhand if it dries out the vaginal area, but if it can dry your skin, then I think you're going to need to talk to your doctor about, or you know what I would do is I would Google, well, hold on, I'll just do it. Hold on. San Marco, hold that thought, honey, and I'm going to come right back to that. Hold on. Let me just search Benadryl real quick. Okay, right there. Antihistamines like Benadryl do cause vaginal dryness. So if they're going to cause vaginal dryness, then that's certainly going to affect your bladder. Claire said, nobody has ever said all those diagnosed with IC has embedded infection. Hun. But it does appear that over 90% of people diagnosed with IC and who have seen an embedded, honey, I'm sorry, I completely disagree with you. We don't have the data to support that. There's no data that supports that statement that 90% of patients diagnosed with IC have it. Somebody needs to go, Claire, if this is what you believe, then somebody needs to go to the European Society for the Study of IC. It's called ESSIC. ESSIC dot, here, hold on. ESSIC. Is it ESSIC.org? Yeah, so the International Society for the Study of Bladder Pain Syndrome / IC, ESSIC. Y'all need to go over to that group and present the data to them and see what they have to say. But there isn't anybody in the interstitial cystitis research groups like it who would ever support that statement. It's just not true. And you think that many doctors would be out of a job if they didn't have, I completely disagree with you on that. I completely disagree with you. Listen, this is not some sort of corporate plot to keep doctors employed by telling patients that they have interstitial cystitis. It's just not true. I have worked with the best doctors in the world personally, and they have the biggest hearts, especially the IC researchers. Now, pharmaceutical companies are a whole nother story. Believe me, if pharmaceutical companies, especially those who sell antibiotics, would love to do that. It wouldn't surprise me if they were behind some propaganda on the use of antibiotics over time. But the IC, to say that IC researchers are doing that, it's just I completely disagree. I mean, I've sat with them at meetings. I have flown to Europe. I flew to the United Kingdom on behalf of IC patients and appeared on the BBC years ago. You know, and every doctor I met there was compassionate, kind, caring, thoughtful. I mean, if somebody could prove that this 90% of IC patients have a chronic embedded infection, that's Nobel Prize worthy. But if Susan Key at the University of Maryland, who did massive studies of bladder tissue looking for that elusive bacteria, she couldn't find anything. All of our biome studies are not finding that. They're not finding that, hon. All right, hold on a sec. So we're getting back to Michelle. Michelle's had IC. She struggled for years. It started 19 years ago. So Michelle, how old were you when it started? You went to the Cleveland Clinic in 2015. They said it was IC. You'd been in the hospital for 5 times. If I let it go, you get a kidney infection. So Michelle, I think it would be, I mean, timing is everything here. So we're talking about embedded UTI. Is there a possibility that you have an embedded infection? Absolutely. Absolutely. You could have an embedded infection, especially if every time you flare, you end up with a kidney infection. You could have a very drug-resistant bacteria in your bladder wall. And so one of the things that you can do to rule that in or rule that out is, in fact, a next-generation DNA urine test. And let's do the King of Kings, the ultimate test to determine if you have an underlying colony of bacteria, fungi, or virus in your bladder. Is going to be a next generation test. It costs $199. Microgen does it, and I built a website on it called bladderhealth.org where you can learn more about it and watch videos of doctors who use it. But the other real question here, Michelle, it might not even be the infection. It might be, why are you prone to infection? Is it because you have estrogen atrophy? The infection is the symptom. It might not be the underlying cause. The underlying cause might be something else in your body that's making you more vulnerable to infection, such as estrogen atrophy in your bladder, estrogen atrophy in your vagina, or even if you have another autoimmune condition, because we do have something called autoimmune associated cystitis. So if your immune system is compromised and not able to fight infection well, that could be why you're struggling with more infection. I have in my family, I have a family member, direct family member, who has a condition called CVID. It's not COVID, it's CVID. It is an age-related and immune disorder. She has no IgG, no natural IgG in her body, immunoglobulin. And she's had recurring bladder infections for years, 25 years, over and over and over again. Now we know why. She's completely immune compromised. So once they got her immune levels up, guess what happened? Her bladder infection stopped. So cause and effect, cause and effect, cause and effect. Anne says, what can I do to relieve urgency frequency? Urgency frequency is being driven by the nerve in your bladder wall. So we have to try to figure out why that nerve is irritated. It could be something as simple as you drinking a cup of coffee a day, especially if you're a little bit older. So Michelle says her symptoms started at around the age of 32. All right. So Michelle, had you had children? Or were you an athlete? Were you a gymnast, a cheerleader, football player, soccer player, anything at all like that? Penny says, I usually have a trace amount of white blood cells when I'm flaring in my urine, but my doctor believes it is inflammation. We calm my body and I'm much better. Inflammation can do so much to the body. Absolutely. Absolutely. So true. We have our diets are filled with inflammatory foods like sugars. So you're doing supplements, diet balancing hormones, eliminating foods that are highly inflammatory, and you drink nothing but well water. I hope, get your well water tested also. Michelle said, yes, you had 2 kids. You were not an athlete. So Michelle, how were your deliveries? Did you suffer any trauma? Did you have any muscle tears during delivery? Betsa says, do you have the phone number for the next generation test? No, go to bladderhealth.org. Sue says she loves it when I go into Sherlock Holmes. Okay, so Michelle, you're going to be our mystery of the day. So Michelle, did you suffer any muscle tears or anything like that when you had your last child or your children? Yes, you did. You had a hard delivery. Okay, so Michelle, as you think about your symptoms today, when you go to pee, can you start your stream right away, or do you hesitate 5, 10, 15, 20 seconds before you can release urine? San Marcos says on YouTube, recently been battling between bladder pain, Hunner's lesions, constipation, lower bowel pain. When my constipation needs to be addressed, I will have to take Lincest, which burns my bladder. You've tried Heather, psyllium husk, nothing is working for constipation, which is aggravating the nerves in your bladder. Well, see, so the challenge here, San Marco, is that your muscles are tight because you're in pain. You've got Hunner's lesions, the most painful form of IC. You've got wounds on your bladder. So every time urine enters that wound, it hurts. And because it hurts, your muscles get tight. So you're stuck in a loop. You're stuck in a loop of bladder pain, muscle tension, bladder pain, muscle tension. And the problem is when your muscles are tight, you get constipated. So kind of concept number 1 here is Physical therapy. Have you had a pelvic floor assessment? And are you doing any physical therapy? All right, Michelle, sometimes it will wait, then sometimes it's right away. Okay. So Michelle, let me ask you this question, because I talked about this in our meeting on Thursday. Have you ever had pee envy? Where you're in a public bathroom and you're sitting there and you're kind of stopping and starting with your little itty bitty stream, and somebody comes into the stall next to you and they let it go. They pee like a horse. And you're sitting there going, oh, how do you do that? Right? Okay. So that's the normal urination, as compared to kind of the stoppy, starty urination is really going to be pelvic floor dysfunction. So did you have a pelvic floor assessment? Has anybody touched your muscles down there, and are they tight? Okay, and San Marcos said you only had one pelvic floor session. Why only one? Seriously, this is not an only one thing. Pelvic floor physical therapy is going to take a lot of time. Okay, so Michelle, when they did your pelvic floor physical assessment, what did they find? Were your muscles tight? David says, so that one nerve controls frequency, urgency. Yes, there is one nerve in the bladder wall called the alpha afferent nerve, which controls frequency, urgency. Okay, so yes, they found tight muscles. So how many pelvic floor sessions did you do? And that goes for you, San Marco, too. Why did you only do one? Why would you only do one? Did it hurt? Ah, typical guy. Sorry, I thought it would not help. Oh, I hear it all the time. So I'm going to tell you a story. I'm going to tell you a story of a gentleman that I was working with. Okay, so actually, his mother called me. He was in his late 30s. It was his mother doing the research. He'd been diagnosed with interstitial cystitis, and he was not doing well. And she called me and said, would you please help my son? And I'm like, absolutely. Let's get him on the phone. So got him on the phone. It takes balls for a mom to call on behalf of a 38-year-old, but she was a sweetie. There are wonderful moms out there. So anyway, she put the two of us together. And so, we started talking, and he'd been diagnosed with interstitial cystitis and for probably a year, and it had completely stopped his life. He was unable to, he was a coach, and he was an Ironman athlete, and he couldn't do Ironman. And he was having trouble coaching. And so we started talking about his symptoms a little bit, and his symptoms were really not reflective of the bladder wall. His symptoms were reflective of the pelvic floor, that he couldn't urinate on time, that he took a while for urination to start. And then, he said, well, I'm an Ironman athlete. I'm at the peak of my career. And I'm like, okay, so wait a second. So we know you have tight muscles because you can't release urine easily. And I think I don't remember the exact specifics, but there were a couple of it. Oh, he was not particularly diet sensitive. He could eat a lot of foods and it wouldn't hurt him at all. So anyway, I went, now let's think about this for a moment. You're on a bicycle for hundreds of miles a week, correct? He's like, yeah. And I go, now let's think about what that bike seat does. It's pushing right into your pelvic cavity, right onto your muscles and onto your nerves. Have you ever heard of bike rider syndrome? He said, no. And I said, this is very common in elite athletes like you. And I said, you really, it sounds like you have a muscle injury. I would go to a pelvic floor physical therapist and get checked out. And he goes, I don't believe you. I'm peeing all the time. I get up at night to pee. It's my bladder. It's my bladder. It's not my muscles. And I said, well, remember, your bladder can be victimized by tight muscles. It's very hard for your bladder to be healthy if they have reduced blood supply because your muscles are so tight. And think about, those elite athlete bodies. They are tight. Their little tushies and their hips and everything, they are working machines, very tight, very compressed. So anyway, he just flat out said, I don't believe you. And he hung up, right? And it's like, okay. Well, he called me back, a month or two later. He goes, Jill, it's really bad. I really need help. And I'm like, okay, now listen, have you had your muscles checked? He goes, no, I don't believe you. Hangs up the phone. Calls me back. And by this time he's crying in pain. It's really quite bad. And it's like, what do you have to lose? Go get your freaking muscles checked, right? He goes, I don't believe you. And I went, I don't care if you don't believe me. Prove me wrong. Go get your muscles checked. Let's see what happens. He called me back, walking out of the physical therapist's office. Oh my God, Jill, you're right. I've got a really bad pelvic floor injury. Okay, told you so. Yeah, told you so. And he was just completely, it's like, it's my bladder. It's my bladder. It's like, no, it's really not your bladder. Your bladder is being victimized by something else. I call it the chicken versus the egg dilemma. Which comes first, the chicken or the egg? And for us, it's which comes first, the bladder or the pelvic floor. For some of you, yes, it begins with a bladder injury like chemo. But for a lot of you, no, it begins with a muscle trauma like having a baby, where you end up with torn muscles after a baby. And Michelle here on Facebook says insurance only paid for about 6. And so so Michelle, did your muscles respond to therapy or are they still tight? Michelle says, it's definitely affected my life. Can menopause play a role in this? I do pee a lot. Yes, when I have a UTI, I cry. It's so bad in my backside. Michelle, you are an anatomical mystery to be solved. You've got several things that you've got to rule out. Number one, you've got to rule out muscle trauma. Okay, we already know you've had a pelvic floor assessment. We already know your muscles are tight. The question is, are they staying tight? Sometimes patients who have long-term tight muscles have it because they have what we call a bony structure abnormality. They've got a bad hip or a bad SI joint or a bad knee or a bad foot. And we have to get to what could be putting long-term pressure on those muscles. So that's concept number one. Concept number two is checking your skin, because if your vulva's dry, your vagina's dry, so is your urethra, so is your bladder. And so menopause absolutely will play a role in this. The drier your skin gets, the more sensitive your bladder gets. But it's the chicken versus the egg. Which comes first? And, if the problem is if you keep thinking that it's just your bladder, and you could do bladder therapies for 10 years, 15 years and never get better. We have to try to get down to the underlying issue, and the underlying issue for many people actually is long-term chronic muscle tension that has restricted blood flow. So is it your muscles? Is it your bladder wall? And also, is it chronic UTI? I'm confused about you getting kidney infections all the time. And I don't know if Dr. Malone Lee talked about this. I don't know if Claire is still here. Claire, was Dr. Malone Lee ever able to make a correlation with chronic UTI causing kidney infections? Veronica says she wants a cup of coffee. I can give you that cup of coffee and you would enjoy it. Where is it? Hold on, let me get it. Hold on. Okay, you want a cup of coffee that I promise you will not hurt your bladder at all? Here it is right here, Dandy Blend. No acid, no caffeine, tastes almost exactly like coffee. You can do lattes, you can do frappuccinos. This is an herbal coffee that is not bitter, it's actually sweet. This is absolutely our favorite. I drink it every day. Sometimes I drink it all day long, especially in the summer. What I do is I make big giant frappuccinos in these, and I'll drink 2 or 3 a day. So I'll do Dandy Blend, a teaspoon of Dandy Blend, fill it halfway with. So I fill the whole thing with ice, teaspoon of Dandy Blend, teaspoon of my Heather's Tummy Fiber, fill it halfway with water, and fill up the rest with coconut milk, and then a little tiny bit of coconut milk vanilla creamer. So the sugar content's low, and it's fabulous. Dandy Blend. Or if we have something called the coffee challenge to figure out if your bladder's ready for coffee. There's a very specific sequence of events, and I just did a TikTok on it. So number one, if you're in a flare, you should only be drinking water or milk. Okay, especially a severe flare. The next thing you can do is chamomile herbal tea or peppermint herbal tea. Why? Because they are smooth muscle relaxants, and they can help your bladder stop spasming if your bladder is starting to spasm. So chamomile herbal tea, peppermint herbal tea are gold. If you do okay with those, and you should, it's very rare that anybody would not do okay with those. Your next step is going to be a rooibos brown herbal tea. It's very reminiscent of coffee. It's not grassy or green at all. We sell it in our store. We have a pumpkin spice rooibos tea that I also drink. Okay. If you do okay with the rooibos tea, your next step is going to be an herbal coffee like Dandy Blend. So there's Dandy Blend, there's Ticino, there's Pero, there's Caffrey Roma. This one is the best by far because it's not bitter at all. It's really perfect for anybody with bladder or bowel issues. This is the bomb. Okay. You do okay with Dandy Blend, then your next step is going to be a true low acid coffee. There is real coffee that is low acid. And the brands that I suggest, we have them in our store, are going to be Bella Rosa or Tyler's or Simpatico. They have true low acid coffee. It's a low acid coffee, comes from a bean that's grown at a lower altitude. And then it is dry roasted rather than roasted in metal bins. That dramatically reduces acid level. And then the third way that we influence acid level is how the coffee is brewed. Do a cold brew rather than a hot brew. Cold brews extract less acid. So we have a bunch of low acid coffees in the IC Network store, icnetwork.org. Carolyn, did you send stars and did I miss them? Thank you, hon. Thank you so much for sending stars. We really appreciate that. Guys, if you find these meetings helpful, please think about becoming a member of the IC Network. We have this great magazine that we send out called the IC Optimist. We just released our winter one a couple of weeks ago. We're doing that for over 20 years now. This is our 20th year of production for our magazine, which includes much more in-depth articles than you will find on our website. Along with you get a lot of freebies too. And if you go for the biggest membership, you get our IC Chef Cookbook and a bunch of other stuff. So Carol says, I'm going to my urogynecologist on April 5th. I haven't seen him in over a year. I have your book. Hold on. I have your book, IC 101. I'm planning on reading it before I go. I've been doing my own research on supplements and medications and anything new. Hold on. Okay, she's asking, so Carol's asking for any other things. I'd like to bring up the compounded estrogen. Is there a particular name for it? No, it's compounded estrogen. That's what it's called. You know, what do I always say? Stop saying IC when you go to a doctor's appointment. Stop it. You have to be more specific. And so whenever you go to the doctor, your job is to get them to study your body. You want them to look at your body. And if you say, I see, they're not going to look as closely at your body as you need to. And so, I would just walk in and prepared to discuss your symptoms. What are your symptoms? How many times are you getting up at night? Do you have frequency, urgency, pressure, pain? And the devil is in the details here. Where is your pain located? Is it on the left side? Is it on the right side? Is it shallow? Is it deep? Is it low? Is it high? What makes it worse? Bending over, sitting down. What makes it better? And I really look for positional pain. Like if your pain is like, I was working with a guy 2 weeks ago and he kept saying, I see, it's my bladder, it's my bladder, it's my bladder. And I'm like, dude, where does it hurt? He goes, by my left hip bone. He goes, dude, it's not your bladder. It's not your bladder. Your bladder is not on the left side by your hip. It's not. It's centered. It's above your pubic bone. He was like, oh. I said, that is not your bladder. That is probably an issue with a muscle or an issue with your hip, but that is not your bladder. So try to be focused on what your symptoms are. Try to describe your symptoms and understand that they may or may not know about subtypes. Subtypes are very new. Only the very top researchers are doing them. Many of them are using their own subtyping system. They don't have to agree with Chris Payne's subtyping system. That doesn't matter. What matters is you getting them to, hey, doc, I can't urinate easily. I sit on the toilet for 5 minutes before I can relax enough to pee. What the hell is that? What is that? Or doc, I really wonder, I think my muscles are part of the problem. Can you do a pelvic exam and touch my muscles and tell me if they're normal or not? Or, I can't get it out of my head. I keep thinking I have cancer over and over, which was very true for me my first couple of years. I was convinced I was dying of cancer with this. And so if that's something you're deeply worried about, just say, listen, I'm really worried it could be cancer. Can you do a urine cytology test just to rule it out so I can stop worrying about it and thinking about it? And the odds are they've already done it anyway. It's an absolute normal workup for somebody who's presented to a urologist with recurring symptoms. If you're bleeding, if you have visible blood in your urine, that is absolutely an appointment with your doctor. And your question is not going to be, do I have IC? Your question is going to be, what is bleeding? Help me understand. I do not understand what is bleeding. Is my urethra bleeding? Is my bladder bleeding? Do I have lesions or is my kidney bleeding? Help me understand what is bleeding. And if you think it's infection, you can say, I'm hearing a lot of talk about infection online. I can't get it out of my head. And you would admit that I've had at least 3 infections so far this year, which you've proven. Can we maybe do the next level of testing to try to identify this very difficult to treat in bacteria that I have? A next generation urine test would be reasonable at that point in time. Penny, thank you for the 310 stars. Veronica, thank you for the 200 stars. Elena says, I've recently read a study about NAC infusions for IC. Are you familiar with that? It was carried out in 2021. What does NAC stand for? Is it N-acetylcysteine? What is a NAC infusion? So NAC has been around for a long time. And yeah, N-acetylcysteine. Don't have any data on that, honey. I don't have any data of that used with interstitial cystitis. It's used to treat critically ill septic patients and more recently COVID-19 patients. NAC has antioxidant, anti-inflammatory, and immune modulating characteristics that may prove beneficial in the treatment and prevention of SARS-CoV-2. Betsa says, what is the microscopic blood in urine? Is that cystitis inflammation? very common for patients to have microscopic blood in their urine, even if you irritated your bladder by drinking coffee a couple days in a row. Understand that when you're, well, here, let me get this picture here real quick. Okay, let us look at this for a moment. This is one of the early educational tools that was used for Elmeron, okay? And this is a three-dimensional picture of the bladder. Now, and I can't fix that light on it. Sorry about that. Well, that might be a little bit better. Okay, so understand that the bladder lining has a thick layer of mucus. They have it's not really blue. That's just for educational purposes. But here you go. So we have a nice thick coating of mucus. And you can see with this picture, this is how they show how they believed Elmeron worked at the time, right? That without the mucus, stuff in your urine reaches these cells. So the question here is, what do these cells do when urine reaches them? If there's something wrong with the mucosal layer and irritants in your urine get here, are they passive? Do they just accept it? Or are they part of the immune response? Well, a lot of the new research is focusing on identifying what these cells do. These cells communicate a stressor, that these cells, when something reaches them that doesn't belong there, will send a message to the immune system and say, help me, invader. And so the immune system then sends white blood cells to the area, right? And so the white blood cells are come up through, you can see here, I don't know if you can see these holes here. The green things are nerves, the alpha afferent nerves, mostly. And this right here are blood vessels. Okay, so now we've got your body's army swarming to the area through the blood cells, right? And so now we've got white blood cells right here, right? It's right here. But how does it get here? Well, it turns out that the capillary opens, it releases them. It releases the white blood cells into the tissue. That also happens to release red blood cells into the tissue. And so that's why we often have microscopic blood in our urine, is that as a response to a flare, because there's no active disease. In some cases, it's just coffee, the irritants in coffee getting down in here, irritating the hell out of the tissue. And your body's going to respond because healing's always happening. Your body absolutely is trying to fix whatever is going on with you. The challenge is we get in the way. We get in the way by drinking and eating the things which are very challenging to that tissue, especially if it's injured. I mean, if you had a wound on your hand, would you pour coffee on it every day? Of course not. Would you pour green tea on it every day? Of course not. If you poured coffee on a wound every day, what would happen to that wound? It'd get bigger. It would hurt more. And so your job is to create an environment that will allow that tissue to heal. That means you have to protect your bladder. It means you have to back off of the irritants and go back to the water, because your body is designed for water. Your body was never designed for coffee, tea, or soda, or energy drinks, or all that sort of stuff. Elena says, can I send you something? NAC? Honey, I'm aware of it. I'm not sure what you want to send to me. Colleen says, does it hurt after you have physical therapy? The second time I had it, I hurt so bad. And if so long, how does it last? So Colleen, you are experiencing what I call the hallelujah moment. That if you go to pelvic floor physical therapy and they touch a muscle and they trigger your pain, that's actually really good news. Because what it means is they found it. And your immediate reaction is going to be, okay, that's it. What are you touching? What are you touching? So we want that first appointment to produce a little bit of pain. And so remember, when you go have a pelvic floor assessment, they're going to study your body from the outside and then internally. They're going to look at how you walk. They'll have you walk up and down in a hallway. They're going to look at your leg muscles, your core, your back. They're looking for anything and everything that can help us understand if you have a myofascial issue going on. Okay. And then once they do the external stuff, they're going to do an internal exam. And the internal exam is really, really important because the only way you can reach these muscles is with a finger in your vagina or your rectum. So let me get out my model here. Here we go. Right? So let me introduce you to your pelvis. So here is your pubic bone, and I want you to notice that it's actually two bones that are connected by cartilage. So your pubic bone is not one piece of bone, it's two bones. Sometimes patients have something called pubic symphysis, especially after having babies, where all of a sudden they've lost stability in these bones. We had one patient had a terrible time walking, and she, after attending one of our meetings, she went back to the doctor. They did x-rays or whatever they did. They determined that her bones were almost detached, and that was why she had so much pelvic pain, bladder pain, et cetera, et cetera. Okay, and the way the human body is designed, the bigger the bone, the more weight it's meant to carry. Thus, the largest bones in your human body in terms of width and size are going to be your hip bones because they're meant to carry the weight of your torso. And of course, we have your spine. And I want you to look at the back. We have your sacrum. So you've got your last disc from your spinal cord, and then you have a triangular bone with 8 holes in it. You can see the holes, and that's actually your sacrum. And I want you to see that your sacrum attaches to your hip bone. So your SI joint is right there and right there. Okay. And then last but not least, we have our tailbone. And I want you to look at our tailbone for a moment because the tailbone, we see so many tailbone injuries. Now that we know to ask about tailbone injuries, it's shocking the number of you who have tailbone injuries. I want you to look at everything that attaches to the tailbone. The tailbone actually moves. It actually helps stabilize your torso when you're sitting and standing. It's very, very interesting. But if your tailbone is out of position, if it's to the left or is it to the right, or if it's poking out instead of going under, we're always going to be looking at the tailbone as a potential source of long-term chronic muscle dysfunction. Okay? Now let's look at it from the other side. So I want you to notice that these muscles are actually fairly flat muscles, and they sit on the bone. You can see that. They sit right on top of the bone. Now, you cannot reach these muscles easily yourself. If you're laying on your back, you might be able to get in just a little bit. But the reason why the physical therapist does the internal exam is look at how far I can stick my finger. Just with a finger, they can go all the way up to your hip bone. They can touch the inside of your hip bone, and touching your bone does not hurt. Do not worry about it. Do not worry about that. Okay, but if they can touch a muscle and reproduce your pain, again, that's your hallelujah moment. That's super, super exciting. It's like, that's it. What are you touching? What are you touching? Now that we know the muscle, as you're now going to be working specifically on trying to rehabilitate that muscle, whether that be your shallow levator ana muscles or your deeper piriformis muscles, whatever. And I would now, for me personally, I will tell you that I have never found physical therapy to be so painful that it was difficult. I never cried during physical therapy, even after my hysterectomy. I never cried. I didn't feel it until, so as I was laying there and she's working internally on me, I just kind of giggle. I mean, it's so goofy. I laugh. Even if it hurts, sometimes I laugh. But the physical therapist is always looking at your face, so looking to see if you're wincing, because you have a way of communicating it if you're not talking. But again, I never found pelvic floor physical therapy to be painful as they were doing it. It was as I was walking out of the office and walking into my car, and especially sitting in my car, that's when I would feel my muscles. And that's when I would feel a pain, especially the last big round that I did. And so that improves over time as your muscles improve. So um, uh, I had involuntary levator antispasms. The levator ana muscles are the shallowest muscles. So these are your levators. So if we put this on, right? So these are your most shallow muscles. And I want you to look. So these levator muscles wrap around your urethra, your vagina, and your rectum. So if these muscles are tight, what's going to happen? It's going to be hard to have a bowel movement. It's going to be hard to enjoy sex, and it's going to be hard to start your urine stream or urinate. So sometimes they're working very shallowly, and then other times they're working very deeply. But the point is if your muscles have been messed up for years, it's not going to go away with 6 treatments. It's going to go away with long-term persistent rehabilitation of that muscle. And that means you've got to get tips from your doctor on what you can do at home, or your physical therapist, what you can do at home when you start feeling those muscles locked down again. And usually that would be we have a big storm coming in, so I'm all dressed for the storm. All right. That would be a glass wand. So normally if you have long-term pelvic floor dysfunction like I do, it's about you starting to recognize when your muscles are starting to get tight, which I could feel this morning again. And then as you're laying on your back, you're probably going to be using the wand internally so that you can actually get to those deeper muscles and do the work you need to do. And it's remarkably helpful. We have another research study from UCLA, which found that 80% of patients with pelvic floor dysfunction respond beautifully to pelvic floor physical therapy. Pelvic floor physical therapy outperforms bladder therapies by far in reducing the symptoms of IC. The other issue is that, whenever you're doing physical therapy, you always need to be asking your physical therapist, are my muscles getting better? Are my muscles getting better? Because for some of you, they aren't getting better. For some of you, they just stay tight. No matter what they do, a day later, a week later, a couple weeks later, the same exact muscle locks down, the same exact trigger points form. So what the hell is that all about? That means that there's something putting stress on that muscle, and that's what we call a bony structure abnormality. So is it a bad hip? Is it a bad SI joint? Like me, I have a bad SI joint and I have a broken tailbone, a formerly broken tailbone. Is it a bad knee? Are you limping? Because if you're limping, you're putting, if you're limping, if you're walking like this and you're limping like this, that's going to affect it. And what Dr. Weiss, our preeminent expert on this, what he found was that 95% of his patients with long-term chronic pelvic floor tension, it went right back down to how they were walking. They had bad feet. And he had to send them to work on their feet to get them to walk correctly. San Marcos says the next step in the treatment for my Hunners is interstim. Fulgurization does not work. Bladder installations do not work. Would be for frequency. Yeah, but San Marco, listen, the problem is interstim is not going to fix the lesion. Interstim will not. It might help the symptoms. Did they so they fulgurated them? Did they come back after fulguration? You know, again, with Hunner's lesions, we're looking number one at viral infection and number two at neuroinflammation. So they came back. So every time they've treated your lesions, they've come back. So honestly, the first thing I would want to do is I would want to have a viral test. And let's see if you have an active viral infection, because if you do, the correct treatment would be an antiviral. And I can give you that research on our website that has linked the viral infections. I can give you the National Institutes of Health research so that you can give that to your doctor and say, listen, I got nothing to lose here. I mean, every therapy you're giving me is not working. I want to know if I might be one of these patients who might have a chronic viral infection in my bladder. And you can find those papers. You can find those papers on our website. Oops, hold on, my bladder fell. There you go. Let me see, San Marco, hold on a sec. Let me see if I can give you the link here. Hold on. It's just a different computer, guys. So, and one of my computers is starting to die, so I'm gonna have to get another one now. This one right here is about 8 years old. This one right here is about 5 years old. All right, hold on a sec. No. All righty. So San Marco, if you go to the IC Network website and search for virus or polyoma, Polyoma, I'm going to give you the link right here. So this is the link to the NIH study, which found the polyoma virus. And then if we go to here and go to here, let's see. I have all that research on the website. It's just not quite in one place. You might find this article. Actually, that's not the right one. Well, start with that one and just crawl through our website, you know. Go into the blog area. There's a lot of, I mean, I've written so many blogs on this. All right. All right. Carol says, I've already been diagnosed with IC over 20 years ago. He's given me lidocaine and stills. It didn't help. Gave me Miratric. Didn't help. He probably doesn't know about the subtypes. I had to tell him about the side effects of Elmeron. He said he hadn't heard of any. I brought in an article about it. I talk about your organization. He is aware of you. In fact, I got his name from your website. Well, that's disappointing that he didn't even know about the Elmeron eye issue. Lisa said, I've had IC for 30 years. My symptoms were bladder pain when urine entered my bladder, and I felt relieved when emptying. No pain when peeing at all. Only pain when urine was in my bladder. I've tried Elmeron, amitriptyline, and other meds with no help at all. About 6 months ago, I started taking turmeric curcumin for other health issues. My bladder is so much better now. How can this be? Well, Lisa, you may actually be in an autoimmune subtype. You know, we have our subtypes now. I mean, clearly your bladder wall driven. And our new subtyping article from UCLA does focus on the bladder subtype, but that said, people in the bladder subtype, I see subtype 1, I see subtype 2, normally responded to bladder therapies. You're not responding to bladder therapies. So in the UCLA subtyping system, they found 3 distinct groups. They found the bladder wall subtype basically as represented with pain as a bladder filled with urine that is relieved by urination. Those patients generally responded to bladder therapies. Their second group, though, had frequency, urgency, pressure pain, but they had more urethral pain and they had pain at the entrance to their vagina. They called this subtype the NUP subtype, not urinary pelvic pain. Those patients did not respond at all to bladder therapies. And I'm very fascinated by that subtype. Then our third subtype was the pelvic floor subtype. So again, frequency, urgency, pressure, pain, but they have more straining to urinate, straining to have a bowel movement, other musculoskeletal symptoms. Those are the patients who did not respond to bladder therapies. They responded to muscle therapies. So the American Urology Association guidelines are very clear now. They're written for patients exactly like you. If you are not responding to therapy, if you're doing bladder therapies and you've done them for a reasonable period of time, 3 months, 6 months, a year, and you're not getting better, the AUA says, stop what you're doing, take a step back, revisit the diagnosis. What have we missed? What could we have missed? Could you have another immune condition like lupus or Sjogren's syndrome? Then you might fall into an autoimmune category for cystitis. Could you have a fibroid tumor pushing on your bladder? Could you have endometriosis on your bladder? Could you have, if you feel a heaviness as the day goes on, if you feel like a heavier weight is in your pelvis until you feel like you're carrying a bowling ball around in your pelvis, that could be pelvic congestion syndrome. So the fact that you're not responding to typical bladder therapies maybe points us away from the bladder. And the fact that turmeric is helping is very interesting, because that does have a bit of an anti-inflammatory effect. Elena says, I started having weird spasms after urination. These get worse in the evening. I take tamsulosin given to me for my urologist, but I don't feel it's helping 100%. Anything else I can do for those spasms? Yeah, a smooth muscle relaxant like ditropan or Detrol. Ditropan is really the medication that is suggested for patients who have okay, so hold on a sec. We have to differentiate here. Are you having bladder wall spasms or are you having pelvic floor spasms? A bladder wall spasm normally begins as the last couple of drops are coming out of your urethra, and you get this sharp, agonizing pain that literally bends you over on the toilet. Like you're stuck. I mean, you're like this for 5 minutes. You don't move for 5 minutes because your bladder is spasming. Right? That is a smooth muscle bladder wall spasm. And the way we stop that, and that's the equivalent of your bladder screaming for help. I mean, that is a sign of a massively inflamed, irritated bladder wall. So the medication that we use to try to stop those spasms is going to be a smooth muscle relaxant, preferably ditropan, also known as oxybutynin. Okay, and it will turn off bladder wall spasms usually in about 15 to 20 minutes. Now, the challenge with oxybutynin is you're not meant to take it all the time, because the more you take it, it kind of deadens the muscles and it makes it hard to pee after a couple of weeks. So when you really need to pee, you can't pee because it kind of deadens those muscles. So that's one concept: smooth muscle spasm, ditropan, oxybutynin. Ditropan is a brand name. Oxybutynin is the generic name. But the other thing is it a pelvic floor spasm? A pelvic floor spasm is characterized by having a burning effect. You might feel a pulling sensation, a pushing sensation. Do you have any pain that shoots down your leg, like sciatica? If it's your pelvic floor, so pelvic floor spasm is going to be triggered if you're straining, because that's a spasm of these muscles. Pelvic floor spasm is a spasm of these muscles, and that's where that pulling, pushing sensation comes. Whereas the bladder wall spasm is a spasm of the muscles in the bladder itself, different types of muscles. So if it's a pelvic floor spasm, then you're going to do a skeletal muscle relaxant. It's going to be like a vaginal Valium suppository, baclofen, which is an oral medication, Valium, which is an oral medication, Flexeril, which is an oral medication, using heat, anything that will relax those muscles. Just did a TikTok on that about what you can do for pelvic floor flares. San Marcos said, is InterStim good for frequency even if you have occasional bladder pain? Honey, InterStim is a mixed bag. It's a big deal. The challenge with InterStim, I just want to put this into context here. InterStim was invented at UC San Francisco. I was a patient at UC San Francisco. That was my regional center. They believed that if you modulated the nerves near the spinal cord with a little electronic impulse, that it would help reduce some of the symptoms and stabilize the nerves. The guy who invented InterStim was Dr. Richard Schmidt, as well as I think it's Emil Tanago. The challenge with InterStim is that it requires surgery. There are hundreds, thousands of adverse events reported to the US FDA about InterStim. One of the challenges is because the incision is near your backside, one of the most common side effects or adverse events is deep tissue MRSA infections. But the device can move, the device can break, the device can shock you. And the other real thing to know about InterStim, the single most important thing, well, God, there's so many things. I have a whole section on our website on neuromodulation. InterStim is not a one-off. If you have a neuromodulation device implanted into your body, it requires constant monitoring. Because if something goes wrong with that device, you're going to need to be seen immediately. If you start getting shocked when you have bowel movements, you need to be seen immediately. The challenge is what happens if you change health insurance or you lose your health insurance? So I had one patient in Florida whose device started malfunctioning. And because she lost her job and didn't have her health insurance, the doctor who implanted the InterStim fired her as a patient. So here she's getting shocked by a medical device inside her body, and the doctor who put it in refused to care for her. And so one of the questions that I would ask that doctor is, all right, number one, what kind of adverse events are you seeing with this? Number two, if my insurance changes, will you still see me? And number three, if you will not see me, who will I go to? Because this girl was abandoned. She was abandoned. And we got her connected up with the company. And it was the company who then found one surgeon in Florida at that time who would work with Medi-Cal or Medicaid, who would take over the care of her InterStim and figure out what was going on with it, wrong with it. So understand that insurance matters. But I think the most alarming thing that's happened fairly recently in the last 5 years was a nurse who lived in a small town, like in Virginia, somewhere in there, North Carolina, somewhere. And there were 3 urologists in the town, and they all told her she had to have InterStim. But she didn't want to have InterStim. But she felt kind of pressured into it. They basically said, we're not going to care for you until you try InterStim. she was a nurse, so she knew her stuff. So she talked to the billing office and she said, is this covered by my insurance? And the billing office in the urologist's office said, absolutely no written pre-authorization is required. So then she called the hospital. She was a nurse at that hospital. So she called the billing office at that hospital and said, is this covered by my insurance? And the hospital billing office said, yes, absolutely. No written pre-authorization is required. So you think you're good, right? Well, she took it one step further. She called the insurance company directly and said, is this covered by my insurance? And that somebody at the insurance company said, absolutely, no written pre-authorization is required. So she didn't get it in writing. She had the implant. A week later, she had a bill for $80,000 and a threat to garnish her wages. Because guess what? They denied it. They denied it. 3 offices, including the insurance company, said it was covered. So she had it done based upon their oral confirmation that it would be covered. She did not get it in writing. And she said when she called me, I would never have gotten this done if I had known this would happen. It was denied. So I have no idea what happened. They were going to garnish her wages. I also want to know who owns it. Who owns the device when it's in your body? Like, who owns it? Because, yeah, San Marco said, that's how I feel the doctor is approaching me on this, pushing it. So San Marco, so here's the deal. There's another form of neuromodulation that doesn't involve surgery that's just as effective. And it was also invented at UCSF, and it was invented as a direct response to all the horrifying complications they were seeing with InterStim. So the doctor at UCSF, who was appalled, said, hey guys, you can reach the same nerve by the ankle bone, and you don't have to do surgery. You can just use an acupuncture needle and a TENS unit, and it's called post-tibial nerve stimulation, also known as urgent PC. And so when I got referred to UC San Francisco, all I can say is, thank you, God, that I did not end up in the InterStim group. I ended up in the ankle stim group. And I can show you my tattoo. Let me see. I have to contort myself here. Let's see. There it is. That's not going to be as easy to see. Let me look at my other one. This one's easier to see. Okay. So, hold on. I have to contort myself to get into a good position. Can you see this little black mark right here? See that right there? So it is 3 fingers above the ankle bone, which puts it right there. And then it's about 1 finger width down. Okay, so here it is right here. So what they do is they take an acupuncture needle, and the acupuncture needle is about 2 inches long, and they stick it right in there. And there's a little bit of finesse. You actually angle it down and angle it down. And then they turn it on. And when they turn it on, if the needle is positioned correctly, what happens is your big toe bends down or your other toes flay out. So with the post-tibial nerve stimulation, you're sitting on the bed in the doctor's office. You've got both ankles exposed. They generally put the acupuncture needle in both ankles. Then they will attach the stimulator to it, and they'll just look at your toes. And if your big toe bends down or your other toes flex out, you're gold. Perfect spot. And then they leave it on for 20 to 25 minutes, and it should never hurt. If it hurts, it's too high, you turn it down, you have control over that. More is never better with neuromodulation, because if you turn it up to the point that it's hurting, you're frying the nerves and you could end up with nerve damage. So I did it with Dr. Stoller, the guy who invented it. By my fourth treatment, I walked into his office with a year-long flare. So when I got into his office and he saw me sit down, he said, "You're in agony right now, aren't you?" And I said, "Yes." So I was in agony when I walked in. Nothing worked. By my fourth week, my fourth treatment, I had my first 2 hours without pain. And by my seventh treatment, I had my first day without pain. So what's so entertaining here is when you have InterStim, they also look for the same toe movement. So only your legs are up in the air and they're working off of your spine. They're working off of your sacrum or off of your pudendal nerve, but they're still looking down at your feet to see if you're getting a toe flex, or they're looking at your rectum to see if it puckers. So the advantages of the post-tibial nerve stimulation are just massive. Number one, very, very few side effects. The last time I looked on the FDA database, there were 2 for tingling in the feet, as compared to hundreds, if not thousands, of severe adverse events, including fatalities. There were 20 fatalities the last time I counted associated with InterStim. Whereas you have 2 little tingling for post-tibial nerve stimulation. So that much less risky, much less expensive, and no surgery required. And if it doesn't work for you, you don't have to have a device removed. They're both approved by Medicare. They have exactly the same success rate. So why not start with the non-invasive one first? I am absolutely convinced that it is what broke me out of that massive pain cycle I was in. It just normalized those nerves. And then once we got things calmed down, that's when my situation started to improve. But I had been in a massive year-long, months-long flare. Judy said, oh, here, hold on a sec. Karen said, I went to see my urogyne second visit. I was rather shocked when she did not examine me. It only ended up being a follow-up conversation. I had all my questions ready, and she told me, great research. Isn't that strange that there was no examination, $395 for a 30-minute conversation? Well, what did you want her to examine? Just say, that's when you just say, hey, I really want you to look at my skin, see if I'm showing any signs of estrogen atrophy, or could you please touch my muscles and tell me if they're tight? Literally, it's a 30-second physical exam. San Marcos says, what specialty doc in your Orlando area, hun? Florida is challenging. I would urge you to go to Google Urgent PC. I think the name of the company was Uroplasty, Uroplasty, but I think that they changed hands. Yeah, so the new company with Urgent PC is Labori, like laboratory, Laborie. Labori. And they should have a doctor list on their website. Okay, you can see who can do it in the Orlando area. And even if they don't have somebody in the Orlando area, you might actually be able to find an acupuncturist who can do it too. Just remember, the golden rule about neuromodulation is it should never hurt. So we had a nurse early on who called me and Dr. Stoller and wanted to do it. And we told her, and I told her, and the doctor told her, it should never hurt. If it hurts, you're risking damaging the nerves. More is not better. Less is better when it comes to neuromodulation. And she didn't listen. And she had it turned really high for a long period of time, and she ended up with nerve damage in her feet. Judy says, it's a B, not a D. Here, hold on. There you go. What is vulvodynia? Vulvodynia is pain on the vulva part of your body, on your labia. So dynia means pain, vulvo means vulva. That's really just diagnosed by your symptoms. Sometimes they might do a biopsy just to see if there's something funky going on. But vulvodynia is commonly felt by women who have estrogen atrophy and their skin gets so dry it's burning like hell. But it can also be caused by tight muscles, especially if you have pain on your perineum. So again, if we look at this model right here, so we've got the urethra, the vagina, the rectum. This right here, this patch of skin between the vagina and the rectum is called the perineum. And when I had really bad vulvodynia when I was in high school and college in my 20s, just off and on. And it felt like somebody'd rubbed my skin off with sandpaper. That's how it felt. I had trouble. I couldn't wear jeans. I couldn't wear certain clothes. Driving a car was rough. And it turns out that while you're thinking yeast and candida and all that sort of stuff, actually what's underneath this but muscle. That in many cases, a perineal pain is a problem with this muscle. There's actually 4 muscles that attach on the perineal body immediately under the skin. Judy said, would nerve pain cause burning after you pee? Probably not. If you have burning after you pee on your vulva, that's estrogen atrophy. Jill says, your volume is all the way up and you're holding the phone to the ear and you can barely hear. You know, Jill, there's usually 2 volume settings. There's a volume setting not only on your phone, but there's also a volume setting on the video itself. So there might be a little microphone that has a little X by it that you might need to turn on. I don't know. Sue, thank you for the 500 stars. Much appreciated. That's one more question. When I have a bladder infections, it is from E. coli. If I do the DNA testing, is it going to show the same bacteria or is it going to show another bacteria? It's going to show both potentially, but what's important about the DNA testing is it will show you not just the species, it will show you the variant. There are lots of different E. coli's, some mild, some severe. So it will be able to identify through DNA exactly the type of E. coli you have and exactly the drug resistancies associated with that strain of E. coli. Lisa says, oxybutynin in small doses helps my hot flashes, but it's scaring me now what you're saying about the side effects. Well, you know, I mean, oxybutynin is an anticholinergic. It's really not meant to be taken for long periods of time. I took it every day for about 6 weeks when I was first diagnosed. And it just got to the point where it just so deadened those muscles that I had trouble peeing. And that's why I stopped it. And they later clarified that oxybutynin is really good specifically when you have spasms. I wasn't having spasms every day. Elena says it feels more like spasms in the urethra. So again, let's think about this for a moment. Your urethra is about the length of your little finger, but this model shows that the urethra is surrounded by muscle. So you could be, so urethral spasms are very sudden and sharp. They stop you in your tracks. Whereas pelvic floor spasms are very predictable. They're very consistent. They happen more frequently. And they tend to have a burning quality to them or make it more difficult for you to urinate. When you're peeing, if you got a full stream, like you can pee like an elephant, then your urethra is good. But if it feels like you're trying to pee through a needle, or your urine is stopping and starting, or it's narrow, that tells us that these muscles here are squeezing and compressing the urethra. John says, can you get a similar benefit to the PTNS if you put a TENS pad down by the ankle? You know, that's one of the things that they were trying. I tried that a couple of times. I never found it to be particularly helpful. I couldn't get the toes to bend when I put the pad down there. Not that the toes have to bend. It just tells us the right nerve is being affected. Kimberly says, I get front of the thigh pain and tightness with tingling in my foot. I was just diagnosed with pelvic floor dysfunction. I have a mild prolapse bladder. Your leg pain started 8 months after the first sign of urinary symptoms. I think I might have pelvic floor congestion because some days the heaviness gets so bad I can barely walk. Yeah, well, we've got three distinct things going on there, Kimberly. Number one, your muscles, you feel tight muscles, especially in your thigh, and your thigh muscles connect into your pelvis. So yes, you easily could have pelvic floor dysfunction based upon that. The tingling in your foot suggests that your muscles are so tight, they're now compressing the nerve that goes down to your feet. I have shared that when I was in my 20s, I noticed now, because realized the 20s was my difficult decade because I had the IBS and the vulvodynia and the migraines and all that sort of stuff, right? And that's all gone now. You just need to know it's all gone now. I was laying on my couch reading a book when I noticed my feet, the bottom of my feet start to tingle. And then about 5 or 10 minutes later, I had to have a bowel movement. And when you think about proximity matters. Here, hold on. Where's my bowel? Oh, there's my bowel demo. All right, so I want you to look at this for a moment. Okay, so again, we have our pelvic cavity. Let's look at it from here. So first thing I'm going to do is I'm going to put on the lowest muscles. And unfortunately, my magnets have stopped working, so they fall off. Hold on a second. Get up there. All right. And ironically, you know, accurately, you can see that these have the things that the other organs positioning, right? That kind of tells you. All right, so we're going to put in, first thing we're going to put in is we're going to put in the vagina and the uterus. So here we go. Then we're going to put in the bladder. There we go. So you can see here that the bladder really is directly, here, hold on. The bladder is directly above the pubic bone. Here, hold on a second. Something weird going on with Facebook. Okay, no, you're just on a Facebook. You guys are on a delay. Sorry about that. Okay, so you can see the proper positioning here, that the bladder is immediately above the pubic bone. All right, so now let's put in the bowel. So the bowel goes in on the left side, right? Now our challenge here is you can see how crowded the pelvic cavity gets. Now, the other thing to remember is we got nerves and blood vessels going through that. So in my case, whenever I have a hard stool coming down the pipeline, there is a moment when it clearly pushes against the nerve that ends up at the bottom of my foot. And so now I know that when my feet tingle, I'm going to probably have to have a bowel movement in the next 15 minutes or so. Interesting, right? I have no shame. I'll talk about anything. So I think, so Kimberly, getting back to you, I think you have pelvic floor dysfunction. I do think that you have muscles so tight that they're squeezing a nerve. And the fact that you feel this heaviness as the day goes on, that gets so bad, that really points us to varicose veins in your pelvis that we call pelvic congestion syndrome. I did an article on that in our IC Optimist last year. That is easily treated by an interventional radiologist, not a regular radiologist. It's a specific type of radiologist. I think you need to go have a pelvic floor assessment. You need to tell them about your thigh pain and your ankle tingling. That's important, or your foot tingling and your heaviness. And I would want additional testing to look for your blood vessels for sure. Lisa says, with neuromodulation, when it's turned up, I get foot drop. I lowered it. Is it okay that I still feel it vibrating? It just should not be comfortable. Zach says, do IC pops inserted help calm down the bladder spasms and subsequently nerve pain? If so, for how long? You know, I don't have any personal experience with that. Ice certainly does help to calm nerves down. Gosh, I think it was Rob Moldwin hold on a sec. I got my workout pants on, guys. Please ignore my so unflattering bottom. So this was the original IC guide years ago. I mean, it's massively out of date now, Rob Moldwin. I swear they talked about that in this book. I might be wrong. It might have been in, was it this book or, so they used to, I think they filled condoms with water and then froze them, but I cannot recommend that. I cannot recommend that. I can't imagine how it would feel. Like, you know how sometimes when you make ice cubes, it sticks to your skin. I cannot suggest or recommend inserting ice down there. I mean, I think if you wrap it in a towel, in a washcloth, and put it on the outside, it's so interesting that some people respond really well to heat while other people respond really well to ice. Thank you, Zach. That's a perfect answer. If you respond really well to heat like I do, that really tells us it's muscular. But if ice feels better, that really tells us it's probably neurological. Thank you. All right, guys. Well, listen, we've been doing this for about 2 hours. I'm happy to take any other questions. I did want to talk about flares, but you had so many questions right at the beginning. I kind of didn't do my little blurb that I would normally do. So let's do last call for questions. Last call for questions. Academy Awards tonight. You want me to talk a little bit about flares? Happy to do it. Totally happy to do it. Okay. And I'm actually, I'm redoing so we have our new book, IC 101. It's not just a bladder disease, right? And I am redoing our diet guide as the IC 101 diet guide. Our flare guide is the IC 101 flare guide. And our medical records kit as an IC 101 medical records file, right? Because this is really what we're focusing on. It's all about education. So here's the deal. We certainly know that there are different types of flares, that some people flare when they eat or drink the wrong food. Other people flare when they have sex or if they're in a car. Is it the same flare? Is it biologically, physiologically the same type of flare? And the answer is no, it's not. You can have a bladder wall flare. You can have a pelvic floor flare. You can have a hormone-induced flare. And you can have a stress flare, and so let's go through the rescue plan for each one of these. So let's just say you've eaten or drunk something you shouldn't have eaten or drunk, and now your bladder's screaming. Especially remember too that you often don't feel the flare until you try to go to bed, and you're laying in bed and you're going, "Oh my God, I've got to pee. Oh my God, I've got to pee." Right? Every 10 minutes, I've got to pee. I've got to pee. So with a bladder wall flare, and again, that usually comes from a chemical exposure or food. The first thing you're going to do is drink water. We have to dilute your urine to try to reduce the volume of the irritant in your urine, right? So concept number one, first hour, drink a couple glasses of water. Not a lot. Don't drink a gallon. Don't give yourself a mini hydrodistension. But let's just increase that water intake. If your urine is a pale, clear yellow, you're good. If your urine is dark yellow or brown, you're not good. Okay. And I just thought of a bad story. I'm not going to show that though. Okay. If after an hour that's not helping, your second thing, but you can do this the first thing too, is alkalinize your urine, especially if you drink something acidic. So let's try to compensate for that acid by you doing a little bit of alkaline to try to get you more towards pH neutral. So you can do pre-leaf, you can do a Tums, you can do a quarter teaspoon of baking soda in a glass of water. The problem with the baking soda is it's sodium. It can raise your heart rate. So we don't want you doing lots of sodium. I was working with a patient who was doing like a couple tablespoons a day. And it was like, no, stop. She goes, oh, that why I have high blood pressure? Yes, that's why you have high blood pressure. So Tums or pre-leaf is better. So we're alkalinizing the urine. Wait another hour. See how you do. Throw in the chamomile herbal tea, peppermint herbal tea as a nice smooth muscle relaxant. Wait a little bit longer. See how you do. If you're still not there with a bladder wall flare, that's when you go to the azo, the over-the-counter version of pyridium. That's the stuff that turns your urine orange that will numb your bladder wall. So azo bladder pain relief tablets, we have it in our store. You can get it at most drugstores. And then that's where you're now at the point where you're going to have to ride through it. If you have been doing home installations and you already know how to do that, a home installation might come in handy at that moment. But with a bladder wall flare, they're probably going to last 24 to 48 to 72 hours. And we all make that mistake. We all have traumatized our bladder, and you're going to have to ride it out. Yeah, and why they always happen at night when you're not available to go to the doctor on the weekend is very, very frustrating. If it gets really severe and you're peeing blood and or your symptoms are just off the charts, call your doctor immediately, get a urine test, make sure you don't have a UTI, and you can ask the doctor to do a rescue instill. So that's the protocol for a bladder wall flare. Pelvic floor flare is different. What do you do with the flare that you get after sex? Now, what's interesting is for a man, the flare begins when they ejaculate because that's when you have the biggest muscle spasm. Whereas for a woman, the flare begins 5 to 6 hours after sex because you go through a period of gentle pelvic floor spasms for 24 to 48 hours after sex to help sperm meet egg. So for that flare, the first thing you want to do is heat. Heat will relax muscles. So putting heat directly over your bladder from the outside, obviously like right here, is ideal. You can use a vaginal Valium suppository. If this is regular and you keep having flares after sex, you can ask the doctor for a vaginal Valium suppository. That would help calm those muscles down. Or you can use oral muscle relaxants. You might even be able to use CBD, something like that. And then, of course, if your pelvic floor muscles are wackadoo and just massively spasming, that's when you get in here with your wand and you can internally gently massage those muscles to get them to relax and release. It usually takes 2 to 3 minutes of work, at least for me to get that muscle to calm down and to stop spasming. So the challenge here is that you've got all the symptoms of frequency, urgency, pressure, pain. You've got all the bladder symptoms. But if it happened after sex, come on, it's a muscle flare. If it happened in the car, it's a muscle flare, even if you're peeing all the time. Now, what about a hormone flare? A hormone flare occurs when a variety, either estrogen or progesterone drops out. Some patients are very estrogen sensitive, others are very progesterone sensitive. All you can really do with that type of flare is protect your bladder, do things that will help control those symptoms, like the chamomile, the peppermint, the azo, and just try to ride that flare out because your hormone levels change hour by hour. That should go away very quickly. But what do you do about a stress flare? So let's say that you have to travel somewhere and you don't like traveling like me. I will always go into a stress flare if you tell me I've got to get on a plane. So what do you do for that? Well, stress flares are completely different because stress flares are really being driven by your brain. They're being driven by your fear. That when your brain senses your fear, you go into fight or flight. And what happens when you're in fight or flight is your heart rate increases, your blood pressure increases, and your muscles spasm. I mean, your muscles get tight. That's the primitive part of your brain that's trying to save your life. Your life is really not at stake, but you've got history. You've got memorized fear. You've had flares before on a plane. You remember those. You don't want to go back and do that again. And so for the stress-induced flare, it's all about getting your brain out of fight or flight. It's about doing some really good mind-body medicine and telling your brain that you're safe. Your life is not at stake. And to try to stop that internal chemical cascade that drives all of these symptoms. And, and of course, heat and things that will keep your muscles from spasming. Whenever I fly, I'm always using my body heating pads on my underwear just to keep my muscles chill. But I'm really rethinking our protocol for a stress flare. I think really mind-body medicine, I Spy, telling the brain that you're safe through good sensory information is important because there's no cognition happening in this process. You can't think yourself out of this. This is about giving your brain good sensory information to tell your brain you're safe. It needs to look at things that are safe. It needs to smell things that are safe. It needs to hear things that are safe. It needs to taste things that are safe. And it needs to touch things that are safe. And I've gone through that before in previous ones. So flares are tricky in the sense that you have to figure out the type of flare you're having, and then you've got to do the right protocol for that flare. So I hope that helped a little bit. If you go over to the IC Network and you sign up to get our free newsletter, our gift to you is our free 40-page flare management guide. Get it while you can because I'm rewriting everything and I'm going to split things apart a little bit more. I hope that helped a little bit. I hope that helped a little bit, hon. When you're in the middle of it and you're up at night and you're almost irrational because you're getting no sleep at all, it's very hard to be patient and to kind of want to get down to the basics. You just want to deal with the pain quickly. And you kind of have to take a few breaths. It's a flare. Like flares don't scare me at all. Flares do not scare me at all. I know what they are. I know they're short term. I know what to do. And I think a big part of this is what we call stepping off the runaway train of emotion. The problem is when you're in pain, you get frightened and you go into fight or flight. And you have to kind of tell yourself, it's just a flare. It's the flare I have every time I ovulate. It's okay. It's a 6-hour flare. It will be gone tomorrow. And not going into that emotional cascade of, oh my God, it's never going to go away. Oh my God, I'm always going to have severe pain. Oh my God, this is the worst. This is the end. Stop it. That's not true. It's just a flare. Flares are short term. And the thing too is the more you learn about your flares, the better able you're going to be to catch them early. Because fighting flares are like fighting a fire. You don't wait until you're bawling your eyes out to do something. As soon as you feel the pulling or pushing sensation, you should be doing your pelvic floor work. As soon as you start feeling your bladder wall getting more irritated, drink your water, alkalinize your urine, act early. And the same is true with pain care. Don't wait until you're bawling your eyes out to do something about the pain, because you're allowing your nervous system to get fully enmeshed in the pain cycle. You got to catch that sucker early. Act early. Cindy says, what do you do when they are long term? Well, that's the hard part, because when they're long term, you're very, very frustrated. And you've got to go back to the basics. You are an anatomical mystery to be solved. We got to figure out the anatomy here. We don't want you to keep doing bladder stuff if bladder stuff is not helping. So this is when you might want to go back to your doctor and say, okay, listen, I don't know what triggered this flare, but I truly don't know what's triggering it. I know that it happened in a long car ride. And so I have to wonder if my pelvic floor is involved, and see if they can get them to check your pelvic floor. See if they can get them to check any of the other conditions. And again, the devil is in the details here. It's often that little tiny weird symptom that you forget to tell the doctor that solves a mystery. Like if you have sciatica, if you have pain shooting down your leg, okay, we know absolutely you have pelvic floor dysfunction and potentially a neuralgia we've got to work on. If you've got painful arousal sensation, we call that PGAD, where you're slightly aroused. It's the middle of the day. You have nothing sexy going on, but you feel this weird, creepy arousal sensation that's uncomfortable. That means you have muscles so tight they're squeezing the pudendal nerve. So the devil is in the details here. You've got to try to write down your symptoms, especially the weird, unusual symptoms. Do you feel a buzzing when you feel down? Do you feel a vibration when you feel down? Do you have pain shooting to the left or to the right or down your leg or up your back? You are truly an anatomical mystery to be solved. San Marcos says, thanks for your patience. I know I hit a lot of subjects. I've been away from this. Honey, I'm really glad that we're able to help. Zach says, my heart goes out to those who suffer. Mine does too. I've been there. I was there for a long time before I got better. That's why I do this. The best part of my job is to be able to give you hope and to give you a roadmap and to kick you in the butt, get you back to your doctor with different questions, with better questions. There's hope, my friends. Your body is wired for healing. Our challenge is we get in the way of healing, and nothing happens overnight. Your bladder is the slowest healing organ in the body. You have to be patient. Your job is to create an environment to support healing. That is why diet matters. Because if you have a wound in your bladder, if you pour acid on that wound every day, you're going to be in pain every day. Letting that coffee go is critical for 3 months, 6 months, just to give your bladder an opportunity to calm down and to regenerate some of that damaged tissue is so important. I can drink coffee. I can drink regular coffee now. My bladder's good. It's healed. It's my pelvic floor that's messed up. My pelvic floor is a long-term journey here. And as I'm sitting here, I just started feeling the little vibration in my left butt cheek, which is my little pudendal nerve entrapment, which is telling me I'm going to have to get up soon. All right, my friends, here's your homework for 15 minutes a day. I need you to do something for your spirit. Go sit out in the sun, go to church if you like church, go walk in the redwoods, get out in nature. Give yourself a little bit of peace. For 15 minutes a day, I need you to do something for your noggin, improve your knowledge. You got to read about this more. Come to our website, read our blogs, read our newsletters. Listen to the podcast we just did with Callie. It's wonderful. For 15 minutes a day, I need you to do something for your body, whether it's making a good bladder-friendly meal or getting down and doing your pelvic floor work. Go do your exercise. Go lay down in your living room like I do and do what you need to do. And last but not least, the best part of your homework is to laugh, because when you laugh, your brain modulates your pain and reduces it. So I want you to laugh every single day. So you have my permission to watch funny movies. I watched that new Red movie from Pixar. Oh, it was so good. what's it called? It was about the girl that turns into the fox when she goes through puberty. It was hysterical, really good. I watched it on Disney. Turning Red. Turning Red. Very, very, very good movie. My ears ring so at night, and so I always have something on all night long so I don't listen to my ear ringing. Yeah, Turning Red. I recommend it. I recommend a good Disney animated movie. It doesn't matter how old you are. There's just good energy there. So, all right, my friends, I will see you all later. Hope to be back on Facebook on Thursday next weekend. Um, and thank you for the condolences. My aunt did pass away yesterday. No, Friday morning. Yeah, she did. My aunt. I've been telling you about my aunt, 90 years old. She had COVID, and she had a. She was in hospice. She had a UTI. Um, her urine was brown for literally 3 weeks, and they were treating her with morphine rather than with antibiotics. And so um, uh, she did pass, and it's a relief. She was ready. She was ready. She wanted to be with her husband, my wonderful Uncle Jim again. So thank you so much for your condolences. I really, really appreciate it. All right, everybody, have a good one. Be well. Let's all watch the Academy Awards. Not that we've seen any of them. I'll see you later. All right, YouTube, you're going first. See you later. And come on over to the IC.